Welcome, everyone. This is a meeting of the Board of Health of the City of Northampton. It's September 18th. It is 5:32. Before we formally open our meeting, is there anyone here for public comment session? Please raise your hand. I don't see anyone. Raise your real hand or your electronic hand. Let me just close my chat so I could have a bigger screen. I don't see anyone.
I don't see anyone, Joanne.
Yep. Okay. Seeing none, we'll move on. Would someone like to make a motion to open the Board of Health meeting?
Move to open the meeting?
Second.
Any discussion? All in favor? Cynthia?
Yes.
Suzanne?
Yes.
Janet?
Yes.
Joanne? Yes. Thank you, everyone. Welcome, everyone. Tonight we have a full roster of our current Board of Health. We have Dr. Cynthia Sowopis, Dr. Suzanne Smith, Janet Grant, and myself, Dr. Joanne Levin. Meredith, can you introduce the staff, please?
Yeah, absolutely. We have with us tonight Deputy Commissioner Michelle Fari. We have Environmental Health Director Amy Hutchins. We have Prevention Director Taylor McAndrew. We have Administrative Assistant Kelly Constantine. We have Public Health Nurse Jen.
Denkevitz.
Denkevitz. Thank you for helping me, Jen. And I believe that's Public Health Nurse Kelly Hughes with us as well. Kelly, can you unmute yourself?
Yes, hi, I'm just listening in. Jen's
Okay.
presenting today. Thank you.
Okay, thank you. And that's it for DHHS staff.
Okay. Great. So first on our agenda is an update from Jen Denkevitz,
Yes.
public health, one of our public health nurses, to talk about the upcoming vaccine season. Take it away, Jen.
Good evening, everybody. Can you hear me okay? So this is our public health update for our fall 2025-2026 respiratory vaccine season. This year, our focus is on supporting the most vulnerable populations of our community by prioritizing the outreach to older adults, individuals facing barriers to vaccination, and this strategy reflects both our mission and the current capacity of our local public health level. Flu vaccination is a critical priority. We are emphasizing that flu prevention this season due to the significant burden of illness seen last year. The flu vaccination rate dropped nationally and in Massachusetts, while flu cases spiked to their highest levels in over 15 years, surpassing COVID-19 in both infections and hospitalizations for the first time since the pandemic. Flu vaccines are safe, effective, and it is the best defense against serious illness, hospitalizations, and unfortunately death. Immunity from vaccine wanes over time, making annual flu vaccination essential. And despite I'm going to talk about COVID-19 a little bit right now. Despite the evolving COVID-19 guidelines and ongoing review by the Advisory Committee on Immunization Practices, ACIP, we remain flu focused due to the predictable season surge and proven vaccine impact. Per the Immunization Division of Massachusetts, COVID-19 vaccines are available for purchase through vaccine suppliers. Ordering the state-supplied vaccines for pediatric population and uninsured adults, including those seen at our public sites such as local departments or community health centers, has not been turned on yet by the CDC. We expect that to happen this week. And the shipment should start arriving in the coming weeks. Until the shipments arrive, children 5 and older may receive a pediatric COVID vaccine in retail pharmacy. COVID vaccine strategy is targeted outreach. We are currently offering COVID-19 vaccines to individuals aged 65 and older at several of our public clinics. This decision is rooted in our commitment to addressing the social determinants of health and supporting those highest risk who may not have easy access to care. That includes the senior centers, those in the pharmacy deserts, the homebound individuals, and others who may not be able to access pharmacy, supermarket, and chain retailers like Walmart. Local pharmacies continue to play an important role and offer COVID-19 vaccines for individuals 5 and up, as well as RSV, flu, and pneumonia vaccine. And we encourage everybody to visit these pharmacies and talk with their healthcare provider about their eligibility for recommended respiratory vaccines. Let's see. Parents seeking COVID-19 vaccines for young children will be referred to their pediatricians, as with other special vaccines, as I mentioned, the RSV, shingles, pneumonia, and this eligibility can best be evaluated by your healthcare provider and making some shared clinical decisions. I want to remind everybody that our public health nurses and our DHHS department continue to monitor respiratory illnesses daily, and we are being mindful about our public health messaging to ensure clear, accurate communication in the face of the rapid evolving guidance from federal, state authorities, including our Governor Maura Healey and Dr. Robert Goldstein. I think that is what I have to say about all that.
Thank you. Questions, comments? Cynthia?
I'm good.
That was just a
Thank you.
wave of your hand. Okay.
Sorry. Thanks,
Any,
Jennifer.
any questions?
I have a question. Yeah, I want to make sure my audio was on.
Mm.
Are we still monitoring the water supplies for COVID?
We are, and I actually have that. Let me just go to the correct screen. We did see a trend of wastewater going up, but it seems to be going down. And I did want to give a little information on as of, let's see, last updated on September 18th, we estimate the emergency room visits related to respiratory illnesses such as COVID, influenza, and RSV are very low right now. Hopefully that helps with that.
Thank you.
Are both of those pieces of information kept updated and on the website?
Yes.
Right. You have access to ED visits for respiratory disease. Is that from Cooley or is that from like state stats?
It's the Massachusetts Department of Public Health dashboard that we refer to.
Mhm. So that's going to be flag a little bit in time, right?
Yeah.
Great. Any other questions or comments?
And just, if I could just, and so Massachusetts is having its own sort of policy for COVID, different than the federal policy. I just want to make sure I understand that correctly. Yeah.
Yes, so Maura.
And that just got rolled out. Okay.
Yes, Maura Healey said that that pharmacies will follow the state guidelines rather than following national guidelines. And that's how we have gotten our pharmacies to adhere to the Massachusetts guidelines.
How about the insurers?
She has also said that insurers have to pay.
Okay,
I don't think all the pharmacies though have it yet because I did call today, CVS, and they weren't well, or maybe it's just some have it and some don't. They were offering Amherst as the closest.
That may be because there's probably a delay. Everyone was sort of waiting a week or two ago, waiting to see what was going to happen, and hopefully they will all have it soon.
Stop and Shop has had it for a couple of weeks.
Yeah. I know I was on the CVS website. We've been doing a little bit of trying to figure out appointment sites, and Greenfield had some appointments, open appointments. Springfield, I know they're not that close to our city of Northampton, but definitely check out CVS, Big Y, Walmart. These folks that we've spoken with and have given us some public comment have been happy with their appointments there, just to provide some reassurance out there.
Thank you.
Any other questions or comments? Great, thanks so much, Jen.
Thank you, everybody.
All right. Next up, our community health needs assessment, known as CHNA. Is that what you call it? Kyle, thanks for being here.
Do you want to say anything before I jump in?
No, Kyle, the last time we were in front of the board was probably about a year ago when we, correct? Time will lose me.
It was
Maybe
Huh?
it's 2 years.
No. They say when you get older, multiply your time by 2. It's probably more accurate. However, so Kyle was introducing the concept about the city of Northampton DHHS doing a Northampton proper community health needs assessment. And I think we were just at the planning phases 2 years ago. And so now 2 years later, Kyle's going to talk to you about our process, about the survey and the results.
Okay, I will share my screen. I'm not sure if I can see you all while I do that. So please, if you have questions while I go, just make yourself heard. Interrupt me. It's totally fine. It is a long presentation. It might feel a little bit like a water hose. I tried to distill it down, but I also wanted to hit the main topics. So again, just interrupt me if you need me to slow down, or anything can and will be available afterwards as well. So yeah, I'm pretty certain when I go into presenter mode, I lose you all. So here we go. I'll just make sure it's presenting. Perfect. So this is the presentation about the community health needs assessment. As a reminder, the main goals of the CHNA were to identify top health needs and priorities of Northampton residents. We wanted to do that in a participatory way, really make sure we weren't just looking at data, but speaking directly to residents and to stakeholders. To use that information to drive programmatic and policy opportunities for DHHS and for the Board of Health. And as we do it, to make sure that we're creating tools and procedures that can be replicated going forward. So making this potentially a regular thing every few years for Northampton, or expanding it to neighboring towns. This is our study design. I was with you 2 years ago, sort of presenting it. Fall and into the winter of 2023, we were doing literature review and stakeholder interviews. Used that to design and pilot a survey, which went live last fall. That survey ran through this spring, and we're now in the results analysis and presentations stage. A little bit about our literature review. It was pretty standard. Just wanted to make sure you guys saw some of the places we looked. Obviously, we pulled from the Cooley-Dick needs assessment. We Community Action Pioneer Valley also does a regional needs assessment, and then lots of sort of health and census and other social determinants data sources. For the stakeholder meetings, we ended up speaking with 11 different stakeholders in town. The main goals of those conversations were to ask the questions: what are the most common health issues or unmet needs that you see in the community? And what information or data regarding the health needs of Northampton do you wish you had that is not currently available? That way we were able to go, and if they had specific requests, make sure we were asking that in our survey. These are the main things we heard. I'm gonna go into results of everything later, but just to show you that we took a lot of the key themes we heard were then integrated in how we designed the survey. So when it came time for survey design, we used sort of community health need assessment toolkits and curriculum around that, as well as some examples from other city, county, and hospital CHNAs. We combined general health concerns and needs so that people had a chance to say it in their own words rather than it coming from the data. But then we also dug a little bit deeper into some of the things that we wanted to know more about based on what we had already heard or seen. So we had personal health concerns. We had a whole section digging into health access, and a little bit around health literacy and health information as well. We had a section on mental health. We then asked if people had dependents living with them and ran them through the same sets of questions specific to their dependents. We had a section about community-wide health indicators, weaknesses, strengths, needs, and opportunities. And then we ended with demographics, and we made a specific choice not to do some of the policy level. We all know housing, transportation, and economic disparities are key drivers of health disparities. But we did want to make sure we had enough information to understand our demographics, and also added a couple specific questions on things that at the department we had seen. So questions around rental quality, responsiveness of landlords, things just that might actually be able to drive programmatic decisions. So I'll just pause quickly. Any questions up until this point? Okay. Our goal when we launched was to reach 5,000 Northampton residents. We had sort of a combination of broad marketing strategies and more individual one-on-one strategies. What I will say is the most success that we had was actually with the reverse 911 or the code reds that you can put out through, I think it's the fire department. And asking residents on text or phone to participate. Every time we did that twice, and each time we saw a huge burst in respondents. We also, as we were administering it, we were tracking who was responding to see if there were populations we were missing. And we were pretty low in males, and specifically sort of the 30 to 50 age range. So we did some targeted ads on social media, and those also were more successful in bringing in the people we wanted to hear from. So I'm going to jump into results. You'll see we reached 2,244 people. So it's a big survey, a lot of power, a lot we can learn from it. That includes both the primary respondents and however many people they answered about as dependents. I'll just give you a sense of who answered the survey. So this is our age. On the left of your screen, you can see the age of our respondents and their dependents. On the right is Northampton census data. I know this is kind of hard to read because they're not the same colors and pie charts, but what I'll point out is we were fairly close in our age distribution. The biggest difference is that the 20 to 29 group by census data, we were much lower than that. That was actually a strategic choice, since a lot of the college-aged kids who come to town for school are transient and don't seek city services. We didn't emphasize outreach to them with the survey. Where the difference was made up was in the older folks, especially age 70 to 79. So you'll see that we had, double the respondents in that 9-year age group than census data. But otherwise, distribution, the other age groups looks pretty good. We asked gender identity questions. Census data asks sex. As you can see, we were sort of overrepresented in females and folks that are non-binary or other or not answering, and underrepresented in male. But that was even lower when we started. So those targeted ads helped somewhat, just probably not as much as we would have liked. Race-wise, we were really close with people that identify as white. In the other, we were a little bit low in folks who identify as Hispanic or Latino. We did make all of our survey materials and marketing available in Spanish, but we only ended up having 5 respondents actually answer in Spanish. Income was pretty good. The dark blue are our respondents. The light blue is Northampton census. You can see we sort of flip-flop. So we're a little below in under 50K, a little over in 50 to 100. So, on the average, pretty close with household income. Same thing with level of education. So we're again, dark blue, underrepresented in high school or equivalent. But as we talked about, we really didn't focus on that age group. And the difference was made up that we had a lot more respondents with an advanced degree, but everything in between was very close to census percentages. So that's a little bit about who we got. We did feel pretty proud of both the overall numbers and the how close we got to census and sort of Northampton information. Yes, Cynthia.
Yeah, thank you so much, Kyle. You may have said this and I may have missed it, but as I recall, when we're putting out the marketing for the survey, really anybody could have taken it, like a worker or someone who's not necessarily a resident of Northampton. Is that true?
It is true. You know, this is a great question. We did ask a question of where they were coming from, and I actually didn't pull that data, but I could go back and look. The last I looked at it, Cynthia, very few respondents lived outside of Northampton, and I could give you a specific answer to that, but I will say it was most definitely majority, if not very close to everybody from Northampton. We did also ask what ward they were from, and we had pretty equal representation across the wards as well.
Great, great. Yeah, don't do any more work to
No.
answer that question. Appreciate it. Thank you.
So I'm going to go through the key findings. This is when it might start to feel like a water hose. I tried to pick sort of the 7 topics that this is across the literature review, the stakeholder interviews, and the survey, some of the key topics that we had significant findings in. So here we go. Interrupt me if you need to. Overall, maybe not surprisingly, in Northampton, people report good, very good, and excellent health. There's your pie chart on the right. We asked about health literacy questions around, did you get the information you needed? Did you understand it? Responses were comparable to national averages. Same thing with having ever experienced discrimination. We asked if people know where to go or would be able to figure out where to go for health resources and information. That was a positive response. And really high vaccine education and awareness. We had a specific set of questions on that to see if there was something more DHHS could do, and people really always seemed to know what they needed to know and get what they wanted. Going into the subtopic of mental health, from our literature review, we know that Northampton rates are higher than state averages in depression, bipolar, post-traumatic stress, and personality disorders. Cooley reports mental health facility admissions over twice the national average, and 5 of our stakeholder interviews, mental health came up. So we had a lot of questions around this. Just when we asked people which health issue is their greatest concern, mental health was the primary response among the overall respondents. But it was also strongly correlated with age. So on this slide, you'll see I filtered for respondents under the age of 50, and almost 60% of people said mental health was a health issue that concerns them the most. We had free text answers that we coded. So we asked people to describe their greatest health concern in their own words. Mental health was mentioned 134 times. Here are some of the quotes. I won't read them all, but non-binary respondent age 30 to 39 said, the greatest concern for me at this time is definitely mental health. There are few affordable and timely options. Give you a minute to read a few of these. We had a section on mental health, as you know, so those were just responses about main health issues. In the section on mental health, here you can see almost 70% of respondents had an increase in anxiety or stress in the past 2 years, over 40% increase in depression or feeling down. When I filter that for respondents under 50, the increase in anxiety or stress goes over 80%, depression or feeling down almost 60%. One thing that I want to point out about this data here is that more respondents under the age of 50 said they had suicidal thoughts or an increase in drug or alcohol use than saying they had none of these in the past 2 years. For dependents, also, we found that mental health was the top concern for dependents age 0 to 18. That's almost 50% of respondents answering for their dependents said this was the biggest concern. More than 50% of them having an increase in anxiety or stress in the last 2 years. And now when we go into the section on community needs, we asked, what do you think the community needs to address mental health issues? The top 2 responses were community support and case management. And when we said, what do you need from your community to better address your health concerns? 190 times we saw social connection come up. So I heard this, we hear female age 30 to 39. It would be nice to have more free or low cost programs in the area so people could connect without needing to spend money. Non-binary age 18 to 24 said Northampton community events like the Taste of Northampton create a sense of community in town that I believe helps mental health. By bringing people together, I believe that Northampton residents feel more connected to their local shops and neighbors and therefore less alone. Yes, Suzanne?
Thank you for this. I was wondering if you asked people to define community support.
We didn't.
Okay, I hear that a lot, and
Yeah.
I'm uncertain as to what the specifics are, that what people consider community help or support, what they would like to see in that specific arena. It's hard to know what to do.
Yeah.
If we don't, is it just an overarching sense that there's no support in the community, or are there specific? I understand that there's a lack of providers in the mental health area. That's obvious to everyone, but I wondered beyond that what people were thinking about.
Yeah, we did not define community support, so we don't know what people were thinking when they answered it. But what I will say is that these questions with the free text, what you need most from your community to better address your health concerns, a lot, as you can see, came up about social isolation or the need for social connection. And also my next slide is talking about, people mentioned recreation and walkability 120 times, but they often linked it to that as a way to connect to others in their community. So I'm reading through the lines here. We didn't define it, but it does seem like a lot of what people are clicking in community support does seem to translate to opportunities for greater connection in the community. So here, some people were specifically talking about recreation or public opportunities as a way to connect. We see someone saying green spaces close to downtown where people can easily recreate, more public spaces for gathering that are not places you must spend money to use. Yes, Janet.
Well, maybe that last comment is similar to the one on the slide before, but somebody mentioned third places, and I wasn't sure what they meant by that.
Yeah, third spaces came up a lot, but it's a newer term. Third spaces are places that aren't your home or your work where you can find community. So it's libraries, it's the bar in Cheers, it's, it's a place where you can go that's not home or work for connection.
Okay, thank you.
Yeah. So yeah, again, on this one, people said things like exercise programs which are accessible to busy caregivers and build in social connections. So a lot of people seem to be correlating opportunities for healthfulness also with opportunities for social connection. Anything else on mental health before I move on? We did have a whole section on healthcare access. I know this is a big and overwhelming topic, but it was mentioned as a need by 4 community partners talking about urgent care not being able to keep up with demand and need for more healthcare employees. When we looked at the numbers, 88% of respondents have had a medical checkup within 2 years. So that's a great stat. But only 50% say that they are able to visit a provider when needed. And we asked them what those barriers were.
Yeah.
And it was far and away, as you can see, about it being the wait too long or people not accepting new patients. Many fewer responses on things about insurance, affordability, provider trust, transportation. It was really predominantly not having enough providers to be able to get into the office. This was the same response when we asked about accessing mental health care services. Again, top responses far and away being about trying to find someone accepting new patients or wait times being too long, not about trust or transportation or cost. Same thing, sounding like a broken record, but same thing when you're accessing mental health services for dependents, taking too long, having to reach out to several providers because you can't get an appointment. This was when we asked people to describe their greatest health concern in their own words. We had asked them sort of health specific, we had asked them to pick things like diabetes, chronic illness. And then when we said to put it in your own words, the most response related to healthcare access. So female age 60 to 69, I am relatively new to Northampton and have had a heck of a time finding a primary care provider. I've gone to Cooley Dickens and urgent care more often than I wish. This person said, non-binary age 60 to 69, primary care is always a challenge in Northampton. It requires people to do more to manage their own health. It was also the most answered topic when we asked, what do you need from your community to better address your health concerns? So again, it's sounding like a broken record, but it's all about access to a physician. I had to wait more than 6 months for an appointment. This person just said public health clinic access. We ended up adding some questions about dental care. This is a shout out to the public health nurse, Jen D, who is with us. She was the one who said she hears a lot about it, and she was right to have us include it. When we filter by household income, specifically under 50,000, which is what the Massachusetts threshold is, dental care became the top health issue concerning respondents the most. We asked them about barriers to dental care, and they were really cost and affordability related. So either not having insurance or not being able to afford it. The other row that you see here, the third top, when I actually read through those responses, it was about coverage not being adequate. So then having significant costs on top of your insurance to be able to afford your dental care. Moving on to housing, like I said, we didn't ask a lot of questions on this. It was obviously mentioned in 5 stakeholder interviews, not obviously, but it was because we all know this is an issue. Interestingly, in the data, you know, Northampton costs are lower than Massachusetts averages, but that doesn't seem to, it still seems, you know, to affect people's health and be top of mind as a concern. We asked a question about what do you think your community needs to improve the quality of life, and it was far and away the top answer. I found this really interesting because even though we didn't focus on housing, this was still what more than half of people clicked on. Yeah, Suzanne.
Could you go back to the slide comparing Northampton? Having heard a lot of discussion about issues, especially housing, in the recent preliminary elections, I think people would be very surprised to see this slide. I think there's a perception that Northampton is much more expensive. Certainly Boston and the greater Boston area contributes to these numbers for Massachusetts. But if I had to guess, I would have guessed that Northampton is at least equivalent to the median for all of these.
Yeah, I can go back into the data. You know, I am curious what it would look like if we were comparing Northampton to sort of Western Mass. Like, what if we looked at either Hampshire County or Franklin, Hampshire, right? Because I think probably my hunch is that this is skewed by greater Boston area data.
Thank you.
It was, like I said, more than half of people said more affordable and better housing would be needed to improve quality of life. We asked folks that were renting if they had an adequate home cooling system, and only 35% of them said always. And 66% of them said that heat affects their health and productivity either moderately or significantly. So we got some good responses around sort of access to home cooling for renters. We had also asked questions about whether they had adequate means of communicating with landlords, and if their requests were attended to within sort of the legally required 14 days. And actually 70% of people said yes to those questions. So sort of landlord responsiveness and quality wasn't as much of an issue. Yeah, Janet.
What was the number of renters or percentage in the survey? I don't know if you went over that.
Yeah, well, so I don't have it at the tip of my tongue, but this circle, the gray square tells you how many people answered that question. So it looks like about 388 people talked about heating, 399 talked about an adequate home cooling system. I can certainly, at the end of this, I can pull that number up for you really quickly. It wasn't a lot. Our renters were, obviously, you won't be surprised, they were sort of lower income. They tended to be younger, and they were concentrated in wards 2 and 3 more so than other wards. But I don't
And two includes the housing around Smith College, I believe.
I think so. Yeah.
Yeah.
So that's what we found on housing. Education and childcare had not been something that came up in stakeholders or literature review, but people identified it as the number 3 and number 6 community weaknesses. So after economic disparities and substance use disorder, people responded about inadequate or underfunded school system. And then after transportation and poverty, lack of available or affordable childcare. So this is clearly of interest to Northampton residents. It also was the 3rd most reported community need to improve quality of life was childcare or after school programs. And in the free text answers of what you need, people wrote about, for example, I have what I need personally, but my kid could use more support at school. We need to invest in children in the school system, or more functional schools so that I don't have to spend so much time running around to make sure my child's IEP is being followed. We had 106 respondents identify as transgender. And it was mentioned, sort of gender affirming care was mentioned in 2 stakeholder interviews. I will mention that, in terms of health issues, the highest health issue concerns, gender affirming care was in the bottom 3rd, but not surprisingly, this is sort of a population of, we have key stakeholders in the community, and for them, gender affirming care and mental health were number 1 and number 2 of their greatest concerns. In this group, we see 65% of them saying they've experienced discrimination when seeking care. More than half identify as having a disability, and about half of them said they don't know or would only sometimes know where to go for resources or information. Another interesting thing is that this group has significant overlap with younger groups and with renters and lower income. And so when we actually look at drivers of some of these responses, age is a driver more so than gender. But I wanted to make sure to point out that this is what we're seeing in folks who identify as transgender on the survey. It was mentioned 26 times in describe your greatest health concern. A male under 18 says biggest concern is loss of access to gender affirming care. unknown, age 40 to 49, access to comprehensive care for my family, especially child-centered pediatric care, and access to trans-affirming care providers who take insurance. And then substance use was mentioned in 2 stakeholder interviews, and it was the second highest community weakness that people cited. Taylor had asked me to look at whether there was a certain demographic that was clicking on this. So, but when I filtered for people who had said substance use disorder was a community weakness, they were pretty representative of the general respondents. So there's not any one subset of folks that are more concerned about this than others, at least in our survey. And then the last thing I'll say is we did have a free text question, as you know, about what you need from your community to better address your health concerns. We've touched a lot on access to care, social connection, financial resources, and coverage didn't come up as a barrier to care when we asked it, but did come up a bit in free text answers. So for example, this person, non-binary, 40 to 49, we really need Mass Health to adjust their income maximum because it's too low. Too many people make too much money to qualify, but still not enough to pay for health care. My dental health has declined dramatically since mental health took away Mass Health took away my access because I make $50 too much. We've talked about recreation and walkability. The other thing I wanted to mention is we had about 96 responses that ended up coded as what I was calling public health. I was thinking about these as sort of things that the department is already doing or could be doing to address public health measures community-wide. Most of these responses were actually about access to testing, screenings, and masks and vaccines for communicable diseases. So male 70 to 79, an increased emphasis on public health measures to reduce the spread of viral disease such as mask wearing, vaccination, etc. That's the findings. I'm going to pause there if anybody has any questions. Like I said, I know it's a lot, and this is even not everything we asked or analyzed. Yeah, Cynthia.
Actually, when I saw this on the agenda, I thought this was going to be a presentation of the triennial China report for Hampshire County. So, which was just released, and I think Meredith, you saw that report, or you heard about it from Healthy Communities at Cooley Dickinson. So, but there were many things in that report. Now that report covers Hampshire, like I said, but there are many things in that report that kind of are mirrored here. That report's quite sobering in terms of what we need to do. But I just wondered, was that taken into consideration at all, or dovetailing these 2 reports?
Yeah, is this the one done by Cooley Dickinson, or is this a different
Yeah.
one?
Yeah.
Okay, yeah, we reviewed the Cooley Dickinson one. We also met, when we started this, we met with Jeff Harness, who is no longer at Cooley Dickinson, but he had overseen the needs assessments for many years.
Yep.
They are very sobering. We tried not to duplicate any of the work they were doing, or at least any of the data points. Jeff's suggestion to us, well, first of all, he said that sort of each year Cooley will kind of pick an area to focus on before they do the needs assessment. So that was also why we wanted to make sure we just had some of these opportunities for people to speak broadly and generally to their health issues and concerns. But he also said that it's pulling from a lot of data, but not really
Yes.
hearing directly from the community. So that was the other thing, really one of our main goals was making sure that we were getting community voices on their topics, not just, and so it does, in that way, it is complementary. You know, we didn't include in here sort of emergency hospital admissions data per se, or you know, we really wanted to look more broadly.
Right. But it's just interesting how there are a lot of dovetails here, because I know the triennial report also incorporates CHES data, which is survey data.
Yes. Yeah.
So so that's kind of cool. And my
Mhm.
other question was, did we have an opportunity to talk to maybe it's not appropriate, I don't know, the individuals in DCC, our clients there, and also our responders there, if their input is reflected here somewhere?
Yeah, we did a lot of heavy outreach with DCC. Both in the pilot stage, we were at DCC asking people to fill out the survey to make sure that we had questions that would sort of reflect what they needed and wanted us to know. And then also when we ran the survey, there was a lot of the responders were out there trying to get people. Jen D, I think, spent a few days at DCC making herself and the survey accessible. So they're certainly represented here, and a lot of the key findings as we go into sort of where do we go from here, a lot of the key findings will overlap and sort of pull on the strong work that DCC is already doing.
We
Great.
also worked with our collaborating partners who work with the same population, asking them to provide ask people to take the survey as well.
Yeah, thank you, Kyle. That's very, very, very informative. Really appreciate your work on this.
Yeah. Michelle?
Yeah, I was gonna say we had so much rigor and robustness meeting with Kyle very regularly and the team for much more time than myself being out for a period for my medical leave. But as I came back to see how thoughtfully the coding and the results from the qualitative portions of people's feedback and how much feedback was given was really surprising, as supported quite a few of the Chinaz and other regional programs and infrastructures around the programs when we were early adopting the outreach for DART. What I found to be really revealing and asking questions of Kyle as she was doing the data analysis, which was well done, Kyle, by the way, very, very well done, was really a curiosity to see how the results might align with what we were seeing with early and preliminary findings through the UMass research of the DCC's services and resources. And I can tell you that there is such a parallel that you can map. And I, in particularly, just made a note as she was presenting the social connection, isolation, mental health, third spaces. That is exactly what we have seen as a reveal over the past 2 years with the DCC, and really, quite frankly, is just very much able to be demonstrated through the engagement of the DCC services. So it's a thrill to know that we were on the right track in designing of what the DCC might do, and then how the community's engaged with us is so validated by the survey's findings that we're on the right track in those ways. So excited to talk more about that in parallels in the future.
Taylor?
Yeah, and to build off that, just really quickly answering Cynthia's question to the what the participants at the DCC are seeing is that UMass, as the evaluator, just wrapped up a second round of interviewing and surveying with participants as well as community responders. So to Kyle's point about not duplicating, we will have another kind of set of data, as well as Hampshire Hope is surveying folks who are actively using drugs or early on in recovery. And this is in tandem with Tapestry. And so I think that's another kind of, group in our local population that would have maybe similar challenges or touch points in our systems as folks utilizing the DCC. So 2 more batches of data to build off of.
And Taylor, you just reminded me, thank you. Just one more, and I thank you for naming those, is we also have the UMass evaluators doing the first ever data analysis that we're aware of 911 call data in Northampton as well. So we'll have another data set of how emergency services are being engaged with in Northampton. So it's exciting for us as DHHS to have the technology and then the partnerships with epidemiology and researchers and folks like Kyle to really critically assess and map data between systems and needs.
Cynthia?
Yeah, just one more. And Taylor, thank you for talking about the work that you do, and it made me think about the opioid money that I'm still not sure if we know how that's going to get dispersed. Will that kind of work in here somehow or help us out somehow here?
Meredith, I think we've been talking internally. We're hoping to meet with you all soon to share some of that kind of more opioid and substance use related data. So more to come, but I think some, access to care and social connection, there's certainly topics here that relate to what abatement funds might be able to do. So
Great. Thank you.
So I'll just, I wanted to share with you all kind of what our plan is. This is the part where also you please jump in with suggestions and ideas. For results sharing, obviously, we're doing this presentation. We'd like to make it to City Council. Cynthia, you just mentioned them, but we are talking about trying to get with the Healthy Communities Committee at Cooley Dickinson Hospital to have this conversation about what are we finding, what are you finding? And all of this will be made publicly available, both the presentation and the final report on the website. We're looking at doing some topic-specific reports, just making the data accessible and available to policymakers. So we want to, have a short brief on our housing data that can go to the Human Rights Commission, education and childcare data, potentially some of the healthcare access data to our policymakers, to our representatives. We know these are topics they're actively working on, but just I think the more we can give them, data directly from residents, the more helpful for advocating and making their case. And then as we develop what the next steps are for the department and the Board of Health and the community, getting it together a shortened report that we tag those next steps onto and making that available to the community, just so they can really see that we're listening and what we heard and what we're doing about it. We haven't gone into too much detail about next steps, but I just wanted to take a little bit of time to talk about what what the data is showing us in terms of where we might go direction-wise. And again, this is open for discussion, of course, now or at any point for ideas. We already talked about sort of sharing whatever data we can that will help inform policy. We didn't ask too many detailed questions on substance use in this survey because Hampshire Hope has had the opioid survey, and next steps wise, we're super lucky to have Hampshire Hope and Taylor and the prevention department who are gonna, take that work forward. When I look at this data, I see at least a few really low-hanging fruit interventions, as I've been calling them. One is, we saw in those free text responses that the community is very interested in more free masks, more COVID tests, access to vaccines. We're already doing a great job of it, but affirmation that it is a need and it is something we should continue to expand if possible. Also, there were questions on the survey that asked about knowing where to go for information and education, but also how people access their information and education. And I think this is a really exciting piece of data because it can help the department know how to reach residents, what is the most effective way to reach residents based on age, based on gender, based on income. I was thinking about this when Jen D was talking about the vaccines, and all of you started talking about, oh, well, where are they available? This could be a public health education opportunity for the department to say, where are vaccines available? Where can you go? And we have some data to say what's going to be the most effective way to do that. Mental health, as we saw, access to mental health is a top concern and need, and the biggest driver is provider availability and wait times. I think this tells us not to focus on as much on cost or transportation, but to really focus on access to mental health clinicians. So is there something that the department can be doing? Is there something that other Northampton city agencies or schools could be doing to make mental health care practitioners available? I also think there's a big opportunity to focus on the 30 to 49 age group. Those results were striking, and there's already a lot of work being done on youth mental health. So this was, for me, this was a really noticeable finding, was really how much even people in the 30 to 49 age range are struggling mentally. Yeah, Michelle?
I just wanted to clarify too, around the access to care coordination questions in the survey. I know that people were looking especially for specialty and more immediate needs around crisis, mental health, substance use, access to care. But was that also something that you feel was demonstrated by and large to all providers and basic health, that you could make the assumption that care access and then levels of care for specialties are increased because of the smaller population of those providers? Or could you explain that just a little bit more?
Yeah, if I understand your question, and we will get to this because you're jumping ahead to healthcare access, but yeah, the need for provider availability was ubiquitous across primary care, across mental health care, and across specialties. And actually, in many ways, even more in a prevention or non-urgent way, not necessarily for crisis, but for, wanting to access services for general health concerns or general mental health concerns. So, we talked a little bit about this, about community support and case management being the top community needs that people said. Um, uh, this is where I was reading the free text, really feeling like people were asking for social connection, that events, public spaces, and recreation were a way to do that. So that had me wondering about, is there a way either as a city to invest in infrastructure, or even as DHHS or as partner agencies to think about programming opportunities that sort of meet healthy living needs and social connection. On the resource navigation and case management responses, that is a focus of DCC. So this is a great affirmation of the work of the DCC. I think it's pretty clear more is needed, either from DHHS or DCC or partner agencies. And I also think it's worth looking at making sure we design the program for different stakeholders. Again, especially with that finding in the 30 to 49 age group. Who are those folks? How are they accessing resources? Is it DCC? Is it some other place where we could get them some of this support? Healthcare access, again, it's all about provider availability and wait times. So it is, telling us to deprioritize cost or transportation. So what can we be doing to increase access to primary care folks? And again, it's the same as with mental health, but maybe the services that we offer for navigating the mental health system can actually just be for navigating the healthcare system broadly. Dental care, this was the one that was about cost. And we had the public health nurses and I had a really great meeting with a community member who was sharing a lot with us about sort of the systemic barriers to dental care, but also sharing some pretty innovative ways that other municipalities are tackling this. So mobile dental clinics, we have the dental student clinic at Stick once a year. Can we organize more of those? Should we be looking at schools or DHHS or other agencies actually hiring hygienists for prevention? And then in our conversation, we were really talking about, well, what would prevention look like? And hearing that, especially among pregnant and postpartum women and pediatrics, there's lots of opportunity for more education. Yes, Janet.
So years ago, when I was working on this issue, there was a difference for dentists in their ability to accept, I guess it was Mass Health, for payment in that they had to either say, I take Mass Health or I don't, and then they could not put a cap on how many, which seemed different from other medical providers. And I don't know if that's still the same or not, but you know, is that, I guess, part of the problem is that we don't have a lot of dentists who accept Mass Health.
Yeah.
It was just striking to, you know, it impacts so many other health outcomes.
Yeah.
And it seems like something we should be able to wrap our hands around and do something about.
Yeah, I think this is where the fun work of the CHNA really begins is, okay, we've got these big glaring needs and opportunities, but what, like, let's dig deeper. Let's really figure out what's underneath it and what we can do about it. And unfortunately, I think what you just cited is getting worse. I don't have the notes from that meeting right in front of me, but the person was talking about how now Mass Health, or the dental portion of it, is being bought out by yet another insurance provider, which is only going to make it less likely that dentists are going to want to work with them and provide services to folks. So it's definitely a concern. And also this we were talking about how a lot of dentists don't want to take pregnant women, or which is actually outdated scientifically, or don't want to take kids because they're a challenging group to work with, but that those are two actually really great touch points for prevention. So, you know, I left feeling optimistic because I think there's a lot of opportunity for education and advocacy even within our community before we have, you know, knowing that we're not going to change the insurance infrastructure anytime soon.
Yeah, there's actually, this is Michelle. I just wanted to mention there was a lot of changes that happened within Mass Health and their insurer setup system and payment facilitation, which has created another significant backlog right now for Mass Health reimbursement by dentists. So even dentists that did accept Mass Health and were available for pediatric care or pregnant and parenting women are even fewer. And the reimbursement has been so problematic that I believe it was backlogged for, in some cases, at the state level. In a recent hearing, it was almost a year, and they were happy that they were getting the margins closer to 3 to 6 months. But they're trying to look at ways at the state level to create more of an incentive and buy-in, and part of why they transitioned, I guess, providers by the state for reimbursement. But it's so problematic, and it's so problematic too that there isn't a lot of discussion about it in the schools as being a health need for families and to educate parents. So, you know, a simple thing like knowing that you can access dental care while you're pregnant is even a barrier with OBGYN in some cases, and then, you know, on through generational life. So just wanted to mention that there's additional barriers happening too that I recently learned more.
Thanks, Michelle. And then the last thing is, you know, gender affirming care. There weren't a lot of next steps that we had sort of asked about or identified out of the survey, but they, as I mentioned, they're the younger group. They tend to be lower income, tend to be renters, and we do know how to communicate with them because of asking them sort of how do you get your information and how do you get your resources. And so when we think about they're looking for access to gender affirming care, mental health care, is there an opportunity to do some education there about where they can find it, what their rights are, and also around discrimination, since we saw really high reports of experiencing discrimination when seeking health care. That is all I have for you guys. Thank you for hanging in there.
Thank you so much. That was really comprehensive.
Yeah.
I was just going to mention that you said about where you're going to share your results. You mentioned that the education and the childcare piece you would want to share with policymakers, but I think it's all important for policymakers. For example, access to healthcare. I mean, I'm a doctor. I'm well aware of the shortage of primary care docs in our area. I don't know what's happening at the State House as far as incentivizing young docs to become primary care docs. I mean, I know when I went to school, there were, national programs, public health programs for people to have their schooling paid for by the federal government if they went to underserved areas. But I don't know exactly what's going on in Massachusetts if the state would consider something like that. But, you know, definitely worth giving them that info and trying to help them come up with some incentive plan.
Dr.
Yeah.
Levin, I just wanted to mention that one of the great programs that DHHS is working with, I think you all had a chance once a while back to meet some of the Perch students that are part of UMass Chan. We still have those 4 students, and we had 4 other students go through a shorter term preceptor program. It's all built on trying to attract those providers to not only, you know, become primaries, but also specialty primaries. And the interesting thing is I'd love to have those students back to meet and speak with you all in relationship to this. One of them is doing a special project with the senior center coming up. Another one did a special project with us helping to develop grant funding skills because providers need to know how to write grants now. And the other one's interested in research we'll be seeing more of soon. But those students have created a really interesting proposal of how they want to also attract other resident students to get to know Northampton in the area that we're talking with them about regularly. But that's unique to us. There is no other public health site out of Worcester except Worcester
Mhm.
that could make that connection of how to really bring providers in to understand the community needs with the public health framework. So that's exciting that we're at least working in some areas, initiatives around that.
Right, right. It's small, but it's a start. Do you happen to know if those 4 students plan on going into primary care?
I do. One of them wants to work in the Franklin County Rural Community Health, and one of them wants to become a specialty in geriatric care. The other one, I'm not quite sure where she's landing yet, but their tuition, yes, is also reimbursable if they stay within the medical field for 10 years. And there's a federal and state program, from my understanding. I don't know all the logistics in those ways, but these Perch students have a significant amount of scholarships as well as part of their program.
Suzanne?
I don't want to forget about nurse practitioners and physician's assistants. There is a very interesting physician's assistant program at Westfield that's really engaging in different ways of approaching things. They were very engaged in addiction treatment. When I was doing that, they were having students spend a month in the office observing. And there's always a difficult time finding time on the curriculum for busy programs like the nurse practitioner program, but a lot of folks from those programs end up in the primary care world. So I don't want to forget about that resource since the entire system is moving in that direction rather than physicians.
Cynthia?
Yeah, thanks, Suzanne, because that was what I was going to mention. I just happened to hear a presentation from MGB looking at the state of primary care in Massachusetts 10 years out. And the word is full stop. Do not expect it to change. There will not be any more primary care docs. And so therefore, we are going to rely on NPs and PAs. And we are so fortunate in this state, as we were told this week, that Massachusetts accepts NPs and PAs. Other states do not. They think it's a lesser than. But we want to make them fully functioning and regard them as peers. So yeah, that's going to be our future. So thanks for mentioning that, Suzanne.
It's our present as well.
Yeah, yes.
It is
yes.
already.
The
Yes.
financing of medical education is a fascinating one that's tied to Medicare on the federal level. And it's unlikely we're going to have a significant increase in the number of training programs for physicians, for training for physicians. It hasn't grown dramatically in the past couple decades.
Yeah, so I think mid-levels, PAs and NPs are our future. The interesting thing about them is that they can change specialties very easily. I'm trained as an infectious disease doc. It's the only thing I can do. But PAs and NPs can be working cardiology one year and be in primary care, then, and surgery. I mean, they can really move around to places that are needed. So there's an advantage to that in a way. Any other questions or comments?
Well,
Go ahead.
just a comment that Bay Path also has I think it's a PA program. So I mean, at least we've got the programs around here, Just have to get these people right up into Northampton.
Actually, did everybody hear that Cooley is now affiliating with Quinnipiac University, and medical students are coming to Cooley starting in the ER and on the psych unit. I don't know if there's going to be a plan for integrating more. We also have NPs and PAs who come to Cooley for education. They go around with our NPs and PAs. So it's starting.
I wanted to bring one other provider, and that's such a good point about MPs. They're keeping us all healthy and strong with the backbone of the work in healthcare is also midwives. And I love how we are the first site to have a freestanding midwifery clinic here with the Seven Sisters. I had a chance to tour that. The commissioner let me take her spot for the reveal when Commissioner Goldstein came and Joe Comerford, and the new DPH legislation was being finalized then. But how incredible it would be to see the state also make the barriers around midwifery much more possible, and the costs in practice outside of the hospital walls. They really, with our maternal health care, provide so much in reducing risks too. It's really amazing how many caring providers there are. We just need more places and spaces for them to be too.
Well, a lot of food for thought.
Mm.
Any other questions or comments? Thank you so much, Kyle.
Yeah.
I did a quick calculation. They're estimated to be 530,000 therapists in the United States. So a population of 340 million. That results, according to my calculation, to 1.6 therapists for every 1,000 people. So that includes, cities, it includes wilderness that we resemble in some ways, but this is a nationwide problem, is my point.
Thank you all for having me.
Thank you.
Thank you very much. It was a great presentation.
Yeah, thank you, Kyle, so much. Kyle's role in getting all of this information together and collaborating it and presenting it to us has been invaluable, and will play a key role in helping us identify the community needs and our next steps. I think as a department, we are now, the next steps for us is taking stock in what we're already doing as a DHHS, whether through our own team or directly within the municipality. And then we're going to assess where is there room to strengthen our role in the DHHS. And that could mean maybe adjusting staff priorities, building new initiatives, improving how we connect with residents to existing services, and then also where are we collaborating with our community partners, and then what is beyond our scope, and kind of breaking it down into those buckets and coming up with a clear 3-year strategic plan is where we're going with that. So Kyle's already gone, but thank you. So next on the agenda, Joanne?
Yes, is our old business, is our regulation prohibiting the manufacture, sale, and distribution of
synthetically derived cannabinoids and synthetically derived kratom.
Great.
You want me to bring it up?
Yep, great. At our August meeting, just to recap, the board voted unanimously 4-0 to approve the regulation of the city of Northampton prohibiting the manufacturing, sale, and distribution of synthetically derived cannabinoids and synthetically derived kratom and unregulated novel intoxicating products. Since that time, I've asked both our city solicitor, Attorney Seawald and Cheryl Savara, to review the regulation. Attorney Seawald completed his review and found no legal red flags. However, he did recommend that under Section D, we removed some of the listing. Oh, thank you. If you can. Well, first of all, he shored up some of our definitions and then we alphabetized them. And then in Section D, under 1, 2, and 3, we listed what products were prohibited, but we also defined them again. And he just said that was unnecessary just to list the product. And then he had nothing more to say except it was great and thankful that we were moving forward with this. You also asked me to reach out to Cheryl Sparrow, which I did. I reached out to her on August 18th and also September 15th, but haven't received a response from Cheryl. And she's actually in Denver this week, so I pinged her again. So while I think it would have been helpful to get her perspective, I don't believe that it should delay us from moving forward. At our last meeting, we did say if there was no legal red flags that we'd like October 1st to be its implementation date. And again, I just want to bring back, the sense of urgency that these unregulated drugs are flooding our retail stores. They're causing significant harm and addiction in our community. And I'm hoping that you all approve with the effective date still October 1st.
Suzanne, you're muted.
Retailers have been notified that this is coming.
Yes.
Okay. I wondered if anybody detected any decrease in sales or availability since that went out.
I don't know. We asked the retailers prior to that to take these products off their shelf on a volunteer basis. So we've done that before. We saw a lot of retailers do that. So yeah, it's hard to say. And a lot of these products, I've been sending products that I've been finding in the internet that are making its way to its shelves. They look they don't look harmful. They just look like vitamins, or they look like energy shots, little bottles of energy shots. And I listened to a great podcast that Michelle actually sent me a couple weeks ago about someone how they became addicted to kratom because it was just, they felt, it was going to do less harm than an opioid or heroin, that, they just need a little boost. So I'm happy to share that out too. It's just, I really think that going back to where we started from, like, these are licensed, permitted stores, and people feel like the products that are being sold there aren't going to do great harm to us. And I've heard a lot of local stories as well, just to let you know. So I'm asking the board at this time, you did pass the regulation, but we were just kind of waiting for legal feedback if the board would take a vote for the implementation of October 1st.
And do we have to re-sign since there's been some editing to it?
No, the intent, as long as the intent didn't change.
Does anybody feel like they need to wait for Cheryl to look at it? I think I would still want Cheryl to look at it. And if she had a major objection, then we can consider editing it, but can we still have her look at it?
Absolutely.
Does
But it
anybody,
doesn't sound like we'd be able to do it before October 1st because she hasn't been able to respond.
right,
Didn't Cheryl provide the language for Belchertown's regulation?
She did.
So we have an idea of her perspective on that based on that language, and it's stricter than what we passed because it included the broad category of kratom, as I recall. So unless her perspective has changed, I think that's where she's coming from. That's more why I was interested in her perspective on how we designated between synthetic and naturally occurring, what she thought about that. But I'm not dependent on her input for us to move forward.
Any other comments?
I'm good with it.
My primary concern was the penalty section because we'd never written before. If you're in violation, the penalty is to suspend all of your Board of Health permits, whatever they might be. So that's what made me a little nervous, but Ellen okayed that.
It's people's attention.
So Suzanne, you said you're okay with it. Cynthia, you want to move ahead? Janet, are you comfortable?
I am. I'd like
Mhm.
to, have a discussion about if and when we would talk about the rest of the kratom that is not part of this regulation.
Yeah.
Suzanne, did I not quote you right?
In what sense?
Are you
Um,
okay moving forward with the
Oh,
October 1st?
absolutely.
Okay.
Absolutely.
All right, so it sounds like everyone is on board to continue as originally planned for October 1st implementation.
Yeah, Joanne, in the regulation, can you bring it up again? We
Sure.
did regulate natural kratom a little bit, right?
No, we hadn't addressed that yet.
We didn't say that, no, you had to be,
No.
that must have been an old iteration that I read. Okay.
No, yeah, no, I don't think in this one we did. Oh, now where did it go?
And a rationale again for not doing it. Suzanne, I think you provided a rationale.
Not including kratom.
Yeah.
Try to paraphrase the FDA commissioner. We think
Yeah.
there's a world of difference from a public health perspective between synthetic kratom and naturally occurring kratom. He said something very close to that.
And that world consists of what again?
Well, it's
Are you gonna get you're gonna get molecular on me now, right now?
I'm sorry.
You're gonna get molecular on me right now.
No, I was gonna the issue with the overdoses is highly likely to be due to the synthetic derivatives because they're much more powerful than naturally occurring.
Thank you. Yeah.
And act much more like a full agonist opioid. The mechanism of action of kratom theoretically should not be a risk for overdose. There, of course, was some disputing that with some of the people that spoke at the public comments. I'm not in a position to debate people on that particular issue, nor to comment on individual cases. But that's the direction that they have moved in. There is a scientific foundation to their policy. I think we're trying to do something because it felt right.
Yeah.
And that if anything is dangerous for anyone, that we want to make sure it doesn't happen in our community. But I think that our timing is such that we were able to benefit from the reports and the press conference of the FDA, and as their rationale as to why they separated those. So I'm comfortable following their lead because they have far more resources than we could ever muster to bring any scientific credibility to this decision.
Amy?
Yeah, I'd just like to add, like Janet, for as far as the you have a definition for raw unaltered kratom leaf powder in here. So it talks about it. And I think as we talk about enforcement and taking all the others and the Delta and the synthetics off the shelf, we're also going to be looking at the labels of the unaltered products as well to make sure, because I'm sure there's going to be a wide variety that's out there that doesn't fit that, but also doesn't fit the synthetic, that we're going to have to, educate ourselves and figure that out.
Amy, you reminded me that the DEA is moving to schedule kratom, and they've already notified the interstate shippers that it's illegal to ship this across state lines. So there are things happening that have some teeth into the enforcement happening on a federal level that support what we're doing. So if they can't ship it, they shouldn't be able to receive it. And we should see a decrease in the availability of synthetic kratom.
Does that apply to natural kratom?
I don't believe so.
But I think the way you guys wrote it, it's, it talks about properly labeled with the full list of ingredients and clearly displayed. I don't think a lot of the ones that are out there even have that. So they're gonna not be considered an exemption. So it's just gonna be more out there that potentially isn't unaltered and raw. That is the other conversation, Janet, you were talking about that you'd like to have at some point.
Yeah.
Joanne, I think you've spoken before about the system in Utah where they're registering manufacturers.
Yes, I can talk about that because I actually called them. But can we just go back to finish the regulation at hand? Meredith, is there something that you wanted to look at?
Yeah, no, Amy pointed it out under the exemptions, that there was a little language in there that we wrote that the raw and unaltered kratom needs to be labeled, list its ingredients, so on and so forth, has to have dosing on it. And when we had someone from the National Kratom Association talk and show us these products that are natural kratom, not synthetic, and I had some of them here, they were not labeled at all. They didn't tell you about dosing. So I think, it's going to eliminate a lot of the products being sold, whether there's the synthetic or the raw. And just to kind of talk about that, just one more point. From my understanding, Suzanne, my brain, yours is just so big, so I'm breaking it, right?
full of air.
The raw unaltered kratom leaf or powder is less risky for addiction or overdose. The podcast that I listened to said there isn't enough kratom that's in raw form that someone could consume in an entire day where they could overdose. It's not possible.
That's the theory based on its mechanism of action. It's a partial agonist. So it should not cause overdose.
But I remember some of the public comment, people were saying, while the association will tell you that you're going to vomit before you go into any kind of respiratory distress or something like that, that the people who claim that, they do have a loved one or whatever who died from it, it was more from like cardiac arrest or some other actual physical cause that was not a depressed respiratory system.
The problem is the lack of testing, even in autopsy.
Right.
The kratom itself is not tested. and the synthetic kratom will test positive. The kratom test will test positive for synthetic kratom because it's derived from the same substance. So these synthetics are the testing for those are almost not available at all. So there is enough synthetic kratom on the market that people have been buying without an awareness of this that may very well account for the people who had serious overdoses and death rather than the raw kratom. It's all based on the pharmacology. I'm not an expert in that, but there's a reason why the FDA commissioner made that statement.
I'm concerned that there are some other effects of this compound other than overdose. Some of the medical sites talked about seizures, and that was discussed as from a case that we heard about, possible seizure. There's also concern about drug interactions, that whether it would potentiate other medications or other things. And I'm feeling like there's just not enough information to say that it's safe. Maybe there's information that the federal government has that we don't have, but they haven't declared that it's safe, and yet it hasn't been outlawed. So it's in this big gray zone.
Yeah, well, this issue of safety, I mean, what is safe? There are more deaths in the United States from Benadryl every year than there are reported from kratom. So is Benadryl safe? It's available over the counter for anyone to buy. There are always going to be people who react badly to certain substances. The only way to avoid that is to ban everything. I'm not being facetious. There's a spectrum of safety. There is a difference in the physiologic mechanism of the raw kratom versus the synthetic. And the belief at this point, at least by the regulators, is that synthetic is the much more dangerous substance.
I agree that the synthetics seem more dangerous, and I'm very happy that we're going ahead with this. But as far as the natural kratom, I guess another question is, does this need to be available in Northampton? If people who feel that this is a helpful substance, can they get it elsewhere? Can they get it on the internet? Yeah. So why do we have to condone it? Why do we have to sell it and have it on the shelf for people who don't know the difference to start taking it?
Would it be on the shelf? Would retailers actually purchase and distribute natural kratom? Where would they get it?
It's not outlawed. They get it from, there's 50 companies listed on the American Kratom Association website of products that they don't say they agree, they condone it, but there are 50 that are sort of have fit their definition of being tested, etc. But also on the Utah, state of Utah government adopted this Kratom Consumer Protection Act, whatever it is that the Kratom Association has been pushing. And so they adopted that into law in 2019. And now on there, you can go to the Utah Department of Agriculture Kratom program has a website, and you can go on there. And I spoke to someone who works there. And what they do is every year they accept an application from a company for a natural kratom product that adheres to what we were guided to. Like it has 2% or less of mitragynine in it, and is not supposed to be mixed with other substances, and is not supposed to have added or synthetic 7-OH. And what they list them on their website every July. They go, that's their fiscal year, July to June, and they accept third-party testing. And I don't have my notes in front of me. They accept third-party testing by some kind of accreditation. It can't just be any third party. It has to be an accredited tester. And that's how they decide which of these products. And again, on their website for this, I think for this year, I think I counted about 50 products that they have said were acceptable. And I asked them if they keep statistics on kratom overdoses and whether they've seen a drop in kratom overdoses or kratom problems since implementing this program. And they did not have those statistics. They do test for kratom. The medical examiner's office does test for kratom when there's an OD. Um, but he said that is it the 7-OH or almatragenine is metabolized very quickly, and so if they don't test someone right away, they may not get an accurate reading on the 7-OH in someone's blood. So, I mean, I could call them back if you have other questions that you would want me to ask of that program, but I was thinking, my opinion now is that we don't really need to have this in Northampton. People can access this on the internet. If they are looking for it and know what they're looking for, they won't just sort of stumble over it in a store in Northampton. So I was very undecided for a long time, and now I'm sort of leaning towards we don't need to have this in our town. But if we decide we want to go forward with it, then I think we need to do things like have it behind the counter, 21 and over, some kind of educational pamphlet that has to go with it. And we might even use the Utah website as a resource for what products are acceptable. But again, that's not our doing. We haven't done the testing. We'd have to be trusting in their work.
Joanne, I do have a question for Utah. I'd like to know, I think it's great they test for kratom, but that really doesn't give the information as to whether it's synthetic kratom or natural kratom. So my question would be, do they test for 7-OH specifically? And if they don't, I'm not sure how helpful that testing is now that we know so much about 7-OH.
Yeah, so I spoke to someone in the general kratom program, but there is a medical examiner's office that deals with ODs, and but she wasn't in, she was on vacation, so I can call them back. So are there any other questions that you would want me to ask a medical examiner who knows the statistics on ODs? So I can ask if they have statistics on 7-OH, but again, as I said, they think it's very hard to get accurate information on that because it's metabolized so quickly.
I just want to add to, if we moved in the way of prohibiting kratom in its raw form, because there is availability elsewhere, I think it would be a lot easier on our inspectors. This is going to be a huge undertaking and learning curve, which we all talked about, but we're willing to take it on. I think obviously it just being prohibited as a whole makes sense on the inspection side. Regardless where we go with that, I do think that we owe it to the general public, maybe doing, and Joanne and I, we talked about this before, considering the growing use of kratom and these synthetic variants, and the misconceptions about it, that we should put some type of fact page on the DHHS website, distinguishing between the two, the raw and the synthetic, and the potential health risks and public health risks, which we can work on.
Michelle and Taylor.
I just wanted to advocate for incremental steps to do less harm is a really positive approach, in the sense where, because kratom is so available in so many iterations and forms, that by taking the step to implement some policy that makes it clear for the greater community that there are concerns around this substance, and that there is a lot still to know. But one fear I have is that the prohibition of kratom in Northampton might push people beyond the boundary lines to make even riskier decisions by trying to purchase it online or trying to find other means and pathways that even the hidden under the shelf access to products or products that are being packaged, as you were saying, in all these iterations, energy drinks, pills and supplements, looks like a vitamin. And by not taking a step soon to show that synthetic kratom is absolutely something that, is not safe and that is not something we want our Northampton residents and community to be exposed to, while there's more defining around the natural kratom product without an unintended consequence of riskier behaviors or choices that people might make that do feel that kratom has a medical use and benefit. And it is really, I wanted to validate what you're saying, Dr. Levin, doing research around this area, there is really no safe way to ensure that kratom is what it says unless you're actually going to the lab where the testing's being done and you're validating that that lab's using standard testing that you would agree with. But there is no doubt in my mind that given the crisis around opioids and the restrictions that people with chronic pain and chronic medical conditions do feel, that this is a life-saving substance, but by saying synthetics are very risky, very unsafe, have many health complications. And I think, Suzanne, what you were talking to is absolutely correct. There isn't a lot of data that shows us that, there's risk of death based on kratom itself, but there's areas that people are researching that, and we might want to be cautious that we don't set up any unintended harm by not being at least balanced in our position. But I understand, I support, and I can see all sides of this. I just wanted to kind of weigh in on it with thinking of a harm reduction approach.
Taylor?
Thanks. To Meredith's point around the educational piece, I just was going to say that some of us at DHHS are in the planning stages of a series of community trainings, and most are based around how to respond to an overdose. But I think it would be a great opportunity for us to add some education around the two different, the synthetic versus not, and just how we cover in all of these trainings, how mixing different substances can lead to higher risk or different responses in the body. So just to say that I think that information would be received well and would be easy for us to incorporate.
Sounds great. Janet?
Well, I do think we should make sure that we go forward with the policy tonight as it stands. And it does sound like, I also can see both sides of the idea of a complete complete ban or not. I don't know. I think we have to keep looking at it. But not to hold up what we have. If we decide that we want to ban the natural plant, I don't know, and Meredith, maybe you can address how we would go about that. It would seem to me that it would be a separate policy, because I think it would need to be explained about why we're making that decision. It's very different. It just feels very different to talk about it as a separate ban, I think, if we decide to go that way.
Cynthia?
I was hoping Meredith would answer, Janet, before I.
I mean, you could do a separate regulation. I don't think you have to, because if you go back to the original regulation that Cheryl Sabara wrote for Belchertown, I think her citations were clear in there, and we could do the literature review again, Janet, but I think it would be confusing to have two regulations, but you can. I'm not saying you can't.
But are you saying that the policy now, though, does not actually ban the,
Mhm.
Right.
Correct.
Right, I think we have a consensus that we're moving forward with the policy that we discussed last time and voted on, so that's moving forward.
right, but then what would you do if we decided to ban the plant-based?
So we would have another hearing to amend our
Oh,
regulation.
to amend it.
Include. Yeah.
I see.
Mm-hmm. Mm-hmm.
So we would also amend the rationale and,
Mm-hmm.
okay,
Exactly. And if we decide that we're not going to prohibit it, but want to restrict, so minimum legal sales age, sold behind the counter, we would amend this regulation as well. So use, right. Mm-hmm.
okay.
Cynthia, did you have more?
Yes, I just, is our time frame here? I know we want to get this done, but is it 1 week or 2 weeks that we get this additional information and that tells us that we want to ban the natural substance as well? Is that what's at play here? Is it a matter of the clock ticking versus a little more research and then do one policy and do the whole thing?
Cynthia, I don't
No,
know where that information would come from.
Well, we
Any
said,
new information.
okay, so then should we just include it right now in the draft policy? Should
Well,
we
that's,
ban?
that's not my opinion, but I
Yeah,
can hear
yeah.
that others have that opinion.
Yeah.
I think you're just talking about getting information from Cheryl Sabara. That was the only thing that we were talking about.
Well,
Could
Joanne was
change.
gonna make another call to her contacts, but I think,
just for more information about, I mean, yeah, if we want to continue the discussion about the natural kratom, there's no clock ticking, there's no deadline. Right now, the policy will go into effect October 1st, because we've all agreed that we want that. And as we feel comfortable and feel like we're ready to make a decision, we can then make a decision. If you feel comfortable tonight, you can make a motion. If you want more information or want to hear from Cheryl or want to do more research, then we can talk about it again next time. So I don't have a good feel for what everybody wants.
I want to go ahead and pass what we have tonight or make sure that we're moving forward with that tonight.
That's
So
done.
that, okay,
That's done.
so that's done. Okay.
Yep.
Yeah, so this isn't a draft regulation, what I provided you. This was,
Okay.
you guys already voted on this regulation, so it's no longer draft. It's just the effective date.
I thought what Cindy was talking about was maybe waiting to add some of that other information, whether it be about labeling or, or banning completely, I guess, but,
I would probably acquire another hearing.
So
yeah, no, I wouldn't be in favor of that anyway.
No.
I think we should go ahead and then as we get more information, I guess my opinion would be to just keep it on the agenda, that
Mhm.
we discuss it, whatever information comes in, as calls are made or Cheryl gets back, that we make sure that we again discuss if it's something that we're going to want to amend at some point, that it's there on our radar.
Yes. Do we want to continue the discussion tonight, or do we want to finish up and bring it up next month?
can I make a recommendation?
Sure.
Catherine. I am talking with Cheryl next week on other matters, so if you can give me an opportunity to have a discussion about this and then bring back to the board next month what she says. And then, so we'll have Kratom on the agenda, and at that point, if a board member wanted to make a motion to amend our existing regulation to include prohibiting kratom, you could do it that, or we can just continue the conversation forward until we have enough, and I don't know what enough means, information for you to move forward.
So we will put this on the agenda for next month. Does anyone have any other comments they want to include now?
And just clarification on effective date?
October
Did that
1st.
pause?
October
That's still
1st.
It's still October 1st. Okay, thank you.
And one more, just kind of throw another wrench into this. If, because we have included in the regulation, a few requirements about the selling of natural or raw kratom. If somebody wanted to include a minimum legal sales age of 21, like we wouldn't need a hearing for that. That's something that a board member could make a motion on. I think those are two important key factors right now, minimum legal sales age and the product has to be kept behind the counter.
So are you saying that we can make an amendment to the current regulation
Yes.
for those two factors because we
Yes.
mentioned the natural kratom?
Mm-hmm. Mm-hmm.
Would anyone like to make a motion?
Is 21 the age that 21 is just because it's 21 and it's an age we use a lot?
Mm-hmm.
Okay.
But we've been talking about increasing that age based off of, you know, brain science. So if you wanted to start here, I mean, that's fine. And throw out a motion. You got to start somewhere with it, right?
That's right.
Not yet. 8 o'clock.
So I'm sensing hesitation. So why don't we just put a pause on it and we'll put it on the agenda for next month. Unless those speaking.
Again, will that delay it? Or is October 1 still?
October 1, yep, is the
Okay.
date. Yep, for all the synthetics.
But the current policy has no comment about age or that it should be behind the counter. Just
Correct.
that it's carved out as an exception.
When you talk with Cheryl, it would be, unless you already know if she has a recommendation regarding age at all.
I'll ask her for sure, but mhm.
So if I'm hearing it right, this means that natural kratom can be available anywhere in the store.
As it reads now, correct.
It could be next to gummy bears and Hershey bars. I mean, does that make sense?
And sold to anyone.
Yeah.
And not necessarily in a tobacconist shop where there's only 21 and over. Anywhere in the city.
So I'd like to make a motion that this policy that has been approved, we add a minimum age requirement of, well, 41, now 21, and have the product be behind the counter, if that's the correct language, or in a locked case.
I can second that comfortably.
What's this about a locked case?
I just don't know when we say behind the counter, some stuff it gets locked up.
So I think the language we're looking for is there's no self-service, like with tobacco. We would take that language,
Okay, thank
like
you.
in our tobacco regulation. Mhm.
I'd amend my motion to say that there would be no self-service of this product in licensed stores.
So does that imply that if somebody asks for it, the clerk will ask for identification, age identification? Or do we need to say that?
I think we need to say that.
I will amend them.
Oh, sorry.
Go ahead.
Go ahead, Amy.
Do they have to ask for identification just to be in the store, Mayor?
No, because Cumberland Farm sells it.
But if you
Brian
say,
sells it.
but if you say 21 and older, that puts it in the tobacconist.
No.
No. Mm-mm.
Oh, okay.
They can get it in Cumberland Farms. The person, the buyer has to be 21 and over, but the store doesn't have to be a all 21 and over store.
Okay.
And on the contrary, tobacconists aren't allowed to sell this because they're only allowed to sell tobacco, nicotine, and tobacco paraphernalia. So they'll have none of
Right.
this.
So in a way, it pushes it to the convenience stores. Yeah.
If it's not,
Um,
if it's not labeled, it can't be sold under the
Right.
current regs.
Mhm,
And I'm gonna guess a whole lot of them are not labeled.
mhm.
So what we have now is a motion to add to our current policy for natural kratom, the minimum age requirement of 21 and over, and that the product not be sold on by self-service. Do we want to add anything about requirement for identification?
I think we should.
Mhm.
Go for it.
So amend the original motion to say, age requirement must be verified. Do we have language by a particular document?
We do.
Okay.
Yeah. In the
That
tobacco
language.
regulations. Yep.
Utilizing the language that we've used in other policies that the minimum age must be verified by the vendor, retailer, whatever, retailer.
Okay, so that's an amendment. We already had a second on the first 2 points. Is there anyone seconding the third point about age requirement must be verified?
I am.
Janet seconds.
Mhm.
So let's,
Can I just add one more point since we're amending? Also, I'm wondering if the board would be in favor of making it a requirement to provide information about the potential risks. And we could come up with that language. I think Taylor was alluding to that fact. Right? Like a little one pager.
Mhm.
Thank you. Okay.
would a board member like to make that amendment?
Yes, I'll make the amendment. I'd like to make it. I'm sorry.
The requirement to
ma-
provide information regarding potential risks.
Thank you. Thank you.
Is there a second?
Question after?
Is there a second on that amendment?
I second it.
Okay. Actually, in addition to a second, is there, so we now have to vote on the amendment to the amendment to the amendment. All in favor of the requirement to provide, the amendment, a requirement to provide information on the potential risks? All in favor? Janet?
Yes.
Cynthia?
Yes.
Suzanne?
Yes,
Joanne, yes. Okay, so that amendment passes to the original motion. The other amendment is that age requirement must be verified, and we'll use the language we've used in other policies, such as tobacco. All in favor? Janet?
Yes.
Suzanne?
Yes,
Cynthia?
Yes.
Joanne, yes? Okay, now we can vote on the amendment, on the motion with its amendments to add to our current policy the minimum that for the natural kratom to have a minimum sales to have a minimum age requirement of 21 and over, and that the product is not sold by self-service. And we've, in addition, the age requirement must be verified, and will be a requirement to provide information regarding potential risks with the sale. That's the motion now. Is there a second?
Second.
Great. Any discussion? Michelle, did you have something you wanted to add?
I did. Thank you for calling on me. I was curious, and I apologize if I'm unknowing of this fact, but in the retailers that have the signage that says 21 years and older, as well as the risks, is that required to be publicly displayed as well as a pamphlet or a handout, or is there any requirement to have like public visibility of the risk of the product, like a sign that might attract more attention or get more potential community health and health literacy thoughts around that language so it's accessible like tobacco? And I'm curious, Meredith, if that is something that might be helpful in your opinion around this for education.
Yeah, if we did that, we'd have, yeah. I don't know.
I'm afraid that would, if you say you must be 21 or over to purchase kratom, that would just advertise kratom more.
That's what I'm
That's
Yeah.
what I was afraid of
I'm
too.
faltering between that, yeah, where the handout with the person who's already aware of this product and is purchasing, it goes hand in hand. Yeah.
Any other discussion? We have a motion on the table.
I just have a question. This does not have to go, these amendments do not have to go to a new hearing.
No.
Thank you.
Mhm.
Any other discussion? Okay, it's now up for a vote. This motion to add these 4 points to our current policy. And I think after that, we'll discuss whether we're going to keep the October 1st deadline. But let's vote on this motion. Janet?
I'm a little unclear.
We're voting on the motion brought up by Cynthia, and it has 2 amendments, but I'll put them all together.
Oh,
The motion is to add to our current policy the minimum age requirement of 21 or over for the sale of natural kratom, that the product not be sold by self-service, and the age requirement must be verified, and the requirement to provide information regarding potential risks.
right. Yes.
Suzanne?
Yes,
Cynthia?
Yes.
Joanne? Yes. That's great.
That's awesome. Thank you.
So Meredith, do you think we can just sort of sneak that in and continue the October 1st deadline?
Absolutely. Yep. Yep. So what I'll do is I'll revise that section because we're already putting parameters around the sale of it. It's not anything, it's not new to the regulation. So that's why we can amend it without having a hearing. But a prohibition or ban of the product itself, not that we have to have a hearing, because again, the only time we have to have a hearing as a board is if we do something for Title V. That's the state requirement. We just do it as part of our policy. So if we were to prohibit or ban kratom in its raw form, then I think we just owe it to the public, and it's our due diligence to have the hearing so we can hear from those who may be affected by that. Just to clear that up for y'all. So I'll put that language in there. We'll get it out to our retailers, and then let them know effective October 1st that products need to be off the shelf or behind the counter.
That's great. We could still continue the discussion, and still a consideration of what we want to do with this natural kratom continue as we just did, or if we want to go further. But I sort of feel like we've got some basics in place right now that were important.
Some great safeguards. I appreciate it. Thank you.
Any other questions or comments before we move on? Great. Thank you, everyone. Meredith, you had some department updates?
Sure. I know we're already over 7:30, but if you can just give me a few minutes. I just want to, and really fast, I'm going to list off some of the things that we have done over the last week or two and that we have coming up, just to kind of give the board a sense of how busy this team is. And it's just amazing when I see it in writing where we are and what we're doing. And I'm literally just taking from like the last week of August and gonna go forward. On August 21st, the inspectors and public health nurses teamed up for tabling at a safety fair and talked about tick education, car seat education, housing, tenants' rights, mold education. They again were at it at Meadowbrook for a back to school fair on 8/27, talking about the same types of products. August, we had our International Overdose Awareness Day. We had our event here in Northampton, but our prevention team and DCC staff went to, I don't even know how many different communities to support their International Overdose Awareness Day. On 9/11, Taylor attended the Western Mass Legislative Briefing event regarding OPCs and other harm reduction legislation. On 9/15, the prevention team supported the Western Mass Recovery Month celebration at Look Park. 9/16, they attended the reentry roundtable breakfast and co-hosted a DHS table at a resource fair with DART and DCC. The Northampton Youth Coalition hosted the first 3 meetings, and I'm just reading from their notes there. There was a robust and diverse turnout, including students from NHS, RS, JFK, and UMass. There were parents, educators from NHS, BSS, and JSS, community partners from Tapestry, Cooley, the Northampton Housing, Spiffy. We have on 9/20, which is this week at Smith Vocational High School from 10 to 2. We're having a car safety event. On 9/26, we're having our DCC 2-year celebration, which I know you've all been invited to from 12 to 4 at One Roundhouse Plaza, where we'll highlight the DCC's contributions to the community and the people we serve. On 9/30, there is a legislative briefing at the State House in regards to strengthening the foundation and investing in public health as an essential service, that I am one of 4 public health leaders that have been asked to testify at, which is super, super exciting. On 10/16, Taylor actually will be presenting about our municipal opioid abatement funds, how we use them, how we collaborate with other communities. We've been asked on 10/23 to talk at the 3-day Mass Municipal Lawyers Conference. It's being held here at Hotel Northampton, and we're going to talk about public health excellence and what that looks like for our collaborative and what it's done for our communities in our collaborative. And the list just goes on and on and on. It's absolutely incredible. The amount of times that folks from the DHHS are asked to speak about our work here locally, on the state level, even on the national level. So I just want to big shout out to my team. We've got a lot of our leaders still here and a nurse. So thank you so much for all your hard work. And thank you to our board for attending some of our events. We really do appreciate the support. So I wanted to thank you.
Can I add two more?
Yeah, absolutely.
So, I have been just watching the nurses in the past month and month before, but definitely in the past month, trying to dissect that information, you know, not coming and then coming about vaccines. And it has been like a whirlwind for them, and they educate me on it. And I just really appreciate that hard work, and it moves so fast for them, and they just keep trying to keep on keeping up. And then the state, well, not so much the state, they've stepped up, but the government is just hiding that information for them to access. So like, excellent job on that. And to the inspectors at that Taste of Northampton, keeping the community safe. So
Good job.
all good work.
It is amazing work. And then lastly, just really quickly, because I know we're completely over time, our team has actually submitted 2 proposals for funding. One is from SAMHSA to expand our DCC capacity and build community anchor partnerships. We're hoping to hear any day now. Yeah, fingers crossed. Thank you, Taylor. It's a 4-year grant, and it's about 1.5 million that we put in a proposition for. Little tricky. We submitted our proposal, and then last week we got this very ugly letter that came from an executive order saying that if you used any language that included harm reduction, migrants, immigrants, so on and so forth. It was just
DEI,
yeah, it was just
accessibility.
awful. So essentially, we had to rewrite pretty much our whole proposal to omit that language. I can't even imagine. I said I don't know who I said it to. I imagine that person from SAMHSA having to send that email to anyone who submitted a proposal, how awful that must have felt for them. But it is
So now,
the we live
now
in.
harm reduction is
Mhm.
not allowed anymore?
Is it okay if I answer?
Yeah.
Sure, go ahead.
So, harm reduction, they have a very, a much more narrow take on harm reduction. So what I will say, which is probably find the light where we can, is that, naloxone and Narcan and overdose, prevention education is well within what they consider okay harm reduction. It's more of the work that Tapestry does. So safe usage supplies, syringes, safer smoking kits, a lot of public health tools that are tied to, you know, HEP and HIV prevention is where things get a little trickier. But I think that's, you know, we focused our harm reduction on the side of education and naloxone.
And you can't use the actual term harm reduction. So do you have a different term that you use, or? You just use the word?
OEND is the acronym for overdose education and naloxone distribution, and they have another similar one, and so it became a lot of
Find and
that.
replace, find and replace.
Yeah, exactly. So the thesaurus too. Yeah.
Mhm. Yeah. And then the other grant that the team put in for, it's called J-Coin, which means Justice Community. Help me, someone. Overdose something. What's the I?
The JRIG stands for it's like an
Oh, innovation grant. Yeah.
research innovation grant through
Right.
NIH is, yeah.
Thank you. And so let's do a feasibility study for overdose prevention sites. And I think we were included that we were going to partner with Tufts University research team to conduct that study. So we've been super busy. I just wanted to highlight that. And
Michelle?
Mayor, we had one other proposal that we were asked to collaborate on, if I could share. It's with UMass Boston and the National Science Foundation and a grant with a team of geoscientists that want to work with us to assess environmental and climate justice impacts on our community members that are the most vulnerable, along with Prevention DCC. So they would be conducting some fact finding, doing some participatory data gathering, and the National Weather Service would be mapping our floodplains for non-federal designated emergencies, and increased risk is a focused area, but they're also going to be looking at heat and cooling, which interestingly came up with the survey of the Chenal. So they asked us to be a host site along with Cambridge as the two sites in Massachusetts. And so we would be working with them and a sub-award for that project, and have an assigned team of geoscientists that will spend, like, I think it's 18 months, which is really amazing because I feel like the intersections with environmental climate and the justice of how we work together and collaborate within the different DHHS divisions can get highlighted in this project too, which would be great.
Thank you, Michelle. So with that, I think we need to move on, and on the minutes, the August minutes have
Yeah, we have, yep, minutes. Did everybody have a chance to look at the minutes?
I have no suggested edits.
Great. Anybody else? Can find it if I have it open here. Here they are. Where'd it go? I lost it. Can you see it?
Yeah.
Yes.
Oh, I can't see it. I think I closed it. Anyway, does anybody have any suggestions, comments? Would anyone like to make a motion?
Move to approve the minutes.
I'll
From
second.
August 21st?
Yes.
I'll second.
Any questions or comments? All in favor? Janet?
Yes.
Suzanne?
Yes.
Cynthia?
Yes.
Joanne? Yes, minutes are approved. Our next meeting is on October 16th, which would be in our regular, on a regular schedule. I may be away, but I guess I can be present. Anybody else have a conflict?
I'm just leaving like super early in the morning on a plane on the 17th, so I hope we'll be able to end the meeting by 7:30
Where are you going?
to Albuquerque
Oh, exciting.
and to Santa Fe. Yeah.
Nice. Everyone else can attend?
Yes.
Okay, we'll keep it. I'll make my business to be there. Any last words?
Motion to adjourn.
Final thoughts? All right, there's a motion on the table. Is there a second?
Second.
Any discussion? All in favor? Janet?
Yes.
Suzanne?
Yes.
Cynthia?
Yes.
Joanne? Yes. Thank you all. Very productive evening.
Thank
Thank
you.
you so
Good
much.
conversation. Thank
Thanks,
you.
everybody. Thanks for all the hard work from the department.
Absolutely.
We take, yeah.
Thank you.
Donuts welcome, Suzanne.